If you look at major clinical trials, including Acuity and Horizons MI, which studied anticoagulation in ACS patients, over 31% of these patients had at least moderate to severe calcification, and these are over 6,000 patients. So very reliable data. If you extend this to other trials, including ADAPT-DES, they really confirm over 30% of patients. And in contemporary drug-eluting stent trials, again, 30% of people that present to the cath lab for either acute or stable coronary disease have severe calcific coronary disease, which makes their interventions much more challenging. And it's important to recognize also that angiography alone is a very poor marker for calcium. In some instances, it's very obvious to all of us, but in other instances, it's very subtle, and it should not be used as the definitive marker of what is truly severe calcific arterial disease. So in one study, patients who had no or mild angiographic calcification, but as deemed by the operator angiographically, really had 61% of those lesions were calcified on IVUS with an average arc of calcium of 71 degrees. So while not severe, definitely there is calcium present. And to say that it's not or mild, I think is perhaps an understatement. So using angiography alone, or fluoroscopy alone, I should say, to determine the severity of calcium is probably a gross underestimate in the vast majority of cases. And why does this matter? Because severity of calcium is linearly correlated with adverse events in interventions, and also in the absence of interventions. So the rate of death, cardiac death, MI, target lesion revascularization, and major adverse cardiovascular events is all sort of linearly proportionate to the severity of calcium, from none and mild to moderate and severe, as you can see on the bar graph here in these two large clinical trials with over 6,000 patients. So whether or not you even intervene on these patients, the degree of calcium, as we know through coronary artery calcium scoring, is also predictive of future events. And mostly for the fellows here, the interventional fellows, when you think about a patient who you maybe know already, or on your setup shots has severe calcific lesions, you want to be thinking about a number of things before you even start your case, or as you plan what you're going to be doing, because you really want to come into these complex cases with a deliberate plan in mind, and even a backup plan. Sort of what are the tools that you will need, whether you have them available to you, what is the access sites that you'll need for those tools, what are the sheath sizes that you're going to require, because you don't want to be changing your plan entirely as you go on through the case. So you want to think about support, especially in the patients with heavily calcified disease, because it's harder to deliver virtually any device in those kind of patients, whether you need to be coming from the right radial, the left radial, if you're intervening on the RCA, will give you much better support, or the groin in the left corner, because of the back wall of the aorta and how the angles and the catheters sit there. What kind of catheter are you going to, or guide catheter are you going to use? The various shapes, and the interventional fellows have obviously become at this point very facile with determining which guides are going to give you much better support. So for instance, ALs and ARs for the right coronary will be much better than a JR guide. But you need to be thinking upfront about what's the right tool for the job here, and what are the risks associated with that as well. What sheath sizes are you going to use, because what devices will you ultimately need to debulk if you need to, what size, atherectomy burr or balloons that you're going to need to treat these patients. And then finally, are you going to need guide extensions to improve your deliverability for devices? What kind of lesion preparation might you anticipate needing, whether it be laser atherectomy if you're dealing with in-stent severe restenosis of underexpanded stents, sometimes rotational atherectomy, orbital, sometimes more useful for very ostial lesions of the right coronary artery, or whether you're going to be needing cutting balloons. Non-compliant balloons are obviously very key and necessary to ensure that you get full expansion of a balloon in those lesions. And then what type of stent are you going to pick? What's the radial force that you might need in a patient that has really severe calcified disease versus someone who has soft plaque? And ultimately, what we're doing all this for is for the durability of the intervention. So we want to ensure that we get good stent expansion, that we don't have underexpanded stents because we were, unable to adequately prep the lesion. And then finally, that we have good stent apposition. So those two things for the junior fellows, they sound similar, but they're very different in terms of the adverse events that they cause. So stent underexpansion means that the stent hasn't adequately opened due to resistance. And that's a risk factor, not only for stent thrombosis, but for in-stent restenosis. And stent malapposition is a big risk factor for stent thrombosis per se, not specifically for restenosis. So, that's ultimately the goal here, is to get a fully expanded stent. And in these calcified lesions, the other last thing we really need to consider is that sometimes drug polymer and drug delivery is reduced. And so that's why they oftentimes come back with more restenosis and worse outcomes than others. And we know that also, not only just the sort of angiographic appearance of the calcium burden is what matters, but also, like I mentioned, other tools are available, such as intravascular ultrasound, that shows you the degree or arc of calcium around the vessel, which is circumferential or not circumferential, or how much of that circumference is taken up by calcific disease. And that is linearly associated with stent expansion. So, if you see a patient that has completely circumferential calcium versus one that only has 60 or 70 degrees in arc of calcium, they're going to be two very different beasts in terms of getting a stent fully expanded. And, a lot of times we deal with, or we have in the past, after the last few years with the introduction of Shockwave, perhaps it has taken away some of the share of atherectomy. I don't know to what extent exactly, but to some degree, certainly. But in the past, atherectomy has been useful in most of these cases. And you have to really weigh the benefits of using these, advanced devices, which are helpful, but also come at some costs. And those costs are increased bleeding risks, dissection, perforation, ischemia from distal embolization, arrhythmia, particularly from using rotational devices in the right coronary with heart block, so on and so forth. Cost of the device itself, procedural time and complexity. These are devices that operators need to learn over times. And also, finally, injury to soft tissue. So using atherectomy in a normal artery adjacent to lesions may also injure tissue and cause inflammation and hyperplasia in those segments as well. So those are some of the limitations. In addition to that, you have apprehensive about undersizing sometimes the burr that we're using because of the risks involved, and also the inability to actually affect calcium that's more deeper within the wall of the vessel. So a lot of the atherectomy devices are really impacting only the calcium that's either within the lesion itself in intraluminal or very superficially within the intima or very proximal media, but not really getting deeper calcium, which can impact stent expansion. So this is an example of, IVUS and how it shows calcium. So for those that are very familiar with it, forgive me, but for those who are not, basically IVUS will create a large shadow of an echolucent area beyond a calcific region. And so depth and thickness or mass of calcium can't be as adequately assessed through IVUS, but it can tell you, very importantly, what's the arc of calcium, or how much of the circumference of the vessel is affected by calcific disease versus just soft plaque. And OCT, or optical coherence tomography, is another tool that came out more recently that is sort of an adjunctive tool in the cath lab to look more closely at the tissue, soft tissue interface. And this can really tell you the location and mass or quantity of calcium and its location within the vessel wall. So on the left, you can see a large calcific nodule that's more medial and adventitial in location, and on the right, a much more superficial area of calcification. And that can help you to decide actually what type of treatment you want to, use. Perhaps on the right, a rotational atherectomy might be able to impact this area of calcification, but not so much a deeper lesion. This is just two other pictures to show you very similar phenomenon. So a large medial nodule here and a more superficial a more superficial lesion here, which impacts a larger arc of the vessel on the right. There's been a lot of algorithms proposed about when to use intravascular lithotripsy, and I'll get into that technology in a second. But in general, I think something that has been put out there is that if a balloon can cross the lesion initially, then you can consider intravascular lithotripsy if you feel that there's deep calcium up front and that a non-compliant or scoring balloon really doesn't adequately treat the lesion or adequately inflate. And that's an algorithm that many operators use up front. If the balloon is not crossable, initially, a compliant or a very, small profile compliant balloon, then up front, you really have no choice but to use some form of atherectomy to open the lesion. And if you can get full expansion with a non-compliant balloon, many people will just go ahead and stent. And if not, then you can use intravascular lithotripsy as an adjunctive treatment post-atherectomy in order to try and affect that deeper medial calcification and improve vessel compliance and elasticity. So the device, for those who are not very familiar with it, is a balloon-based catheter system. It's designed to fracture both intimal and medial or deeper calcification using a transfer of electrical energy into sonic pressure waves or ultrasonic pressure waves. The three goals are: one, to minimize soft tissue trauma, which occurs with atherectomy and notably does not occur to that extent with this device; to simplify procedures in a bit because it's a balloon-based catheter, so it's sort of much simpler for the operator to use and much more facile for those who haven't used it frequently, to decrease the time and complexity of procedures and maintain and improve the outcomes ultimately. And the technology is really based historically on what was used to treat kidney stones. So that was extracorporeal shockwave lithotripsy. And that is basically a technology that's been around for 30 years and became the first line treatment for treating over 70% of kidney stones. And the technology was essentially flipped or reversed on its head. So in kidney stones, they take a large beam or array and try to focus that array onto a target lesion, which is the renal stone. And in this case, they've turned that upside down and taken an emitter, which then sends out an array of sonic pressure waves sort of diffusely into the vessel to affect all of the entire vessel architecture circumferentially in 360 degrees. So it's really an interesting way that they used that technology to turn it around and used it in intravascular treatment of calcified disease. So what is an actual shockwave? It's a dramatic increase or a jolt of sonic pressure waves that generate 50 atmospheres of pressure for an exceedingly short period of time and then dissipates the energy within a few microseconds. So, non-compliant balloons will increase the pressure up to 26 or 30 atmospheres at most, and I think few people would even use it at that pressure unless they absolutely had to, and that pressure is transmitted sort of somewhat slowly over time, and this is very quickly with a dramatically higher atmospheric pressure. So there's a transfer of electrical energy from a generator that's hooked up to the balloon catheter via an electrical cord, and that electrical spark ignites an emitter that is inside the fluid-filled balloon with 50-50 saline and contrast, and that induces the formation of a rapidly expanding and collapsing vapor bubble. And this initiates the transfer of an acoustic or sonic pressure wave. So it's not one particle per se that's physically moving continuously in space and then releasing that energy in the calcified lesion. It's actually a wave or a transfer of mechanical energy by moving neighbor particles and then returning each particle to the base equilibrium state. So it's basically an ultrasonic pressure wave. And the energy dissipates when there's a change in the medium density. And so that's why it's really important to know that if you have a balloon that is not completely and consistently filled with a mixture of saline and contrast, and there's air in that balloon, then there's a large change in density as the wave is propagating, and it's not going to reach where you think it's reaching. So the device is going to be rendered essentially much less effective, if not ineffective, in that situation. So that's why it's really important to prep the balloons very appropriately, and we'll talk about that in a second. So soft tissue interface, because there's not a dramatic change in density between soft tissue and the air and the contrast media in the balloon, it does not cause a large dissipation or transfer of that sort of shockwave per se. So it limits damage to endothelium and areas of healthy intima, and that, according to, in theory, the device won't promote intimal hyperplasia in areas of healthy tissue, and it's really going to focus its treatment on the plaque that you're trying to modify. So this is basically what the system looks like. There's a small generator that's hooked up to the connector cable to basically a wand that has the button that you control to deliver pulses, and then that is in turn hooked up to an IVL catheter. And the IVL catheters are all 014 guide wire compatible. So just to sort of compare again with atherectomy, Shockwave is for balloon crossable lesions initially only as an upfront technology for calcium modification. It has a simple learning curve with a very simple, easy, facile setup. There's no guide wire bias because you're using a balloon to treat the entire lesion. So there's 360-degree treatment of the target lesion. There's theoretically no, and we'll look at the data, but no or less embolization compared to atherectomy. There's little healthy intimal injury. And there's some question about whether or not it's more cost effective. That remains to be determined versus atherectomy, depending on how this evolves. So atherectomy is for balloon uncrossable lesions. You have to, upfront, obviously debulk that lesion in order to proceed with the intervention. It does require experience, depending on the kind of device that you use, in order to become facile with it. There are more chances for different types of complications. There is guide wire bias at times. There are limits, including vessel tortuosity, et cetera, deliverability, injury to adjacent normal intimal tissue, and distal embolization. So in general, the use of this catheter requires you to prep it a little bit differently than you would a normal balloon. So I typically prep it, first of all, certainly with a stopcock. Not all of us prep balloons with a stopcock, which is, obviously generally okay. But prepping this catheter, definitely you want to use the stopcock and at least 2, if not 3, complete preps with a 30 cc syringe to remove all of the air from the catheter. And then if you inflate it in the body and you do see an air bubble, it's important to actually deflate it, get that air bubble out, and reinflate it so that the balloon is consistently filled without air, with a 50-50 mixture of contrast and saline. Basically, we've been through all of this so far. It's 014 guide wire compatible. The coronary is a monorail. The peripheral catheters are over the wire, which is what we consistently use for those cases for the most part. And the coronary catheter is 80 pulses with 8 total cycles. And you typically deflate after 10 pulses, depending on obviously your patient and how much they can tolerate the ischemia. You may have to deflate less than that, and where you're using it. If you're using it in proximal LAD, left main area, or somewhere where there's more ischemic territory or there's not as much ischemic preconditioning, you may need to use it with less than 10 pulses at a time. Definitely. So if you misfire, which is called firing the emitters with your, by pressing the button when the balloon is not inflated, you can rupture the balloon. So just be very cognizant of going up on the balloon first, and only to 2 atmospheres initially. The whole point of this balloon is not to injure or dissect the vessel up front. So you don't want to go to high pressure with this balloon at all. So 2 atmospheres for your pulses, 4 atmospheres perhaps, and then ultimately, to show that the balloon is adequately inflated or fully inflated, you can go to 6 atmospheres, which is the nominal pressure. So there's a number of catheters available, including peripheral and coronary. So on the peripheral side, there's now the M5 Plus. Previously, we had only the M5 catheter. There's now a catheter called M5 Plus, and that catheter is twice the speed of the previous version. So a lot of peripheral vascular interventionalists complained that they were taking too long to do their cases because it took 300 pulses, and that's 300 seconds, which is 5 minutes to treat an SFA lesion. And the company came back and said, okay, we'll make it fire twice per second instead of once per second. And so now 300 pulses is delivered in 150 seconds, so 2 minutes and 30 seconds rather than 5 minutes. So I've used that catheter. It's it's great. It goes up to 8 millimeters in diameter, whereas the previous version only went up to 7 millimeters in diameter. So there is an added benefit for the iliac system there. The Shockwave S4 catheter was designed for below the knee use. It's a smaller catheter, so it's only 40 millimeters as opposed to the M5, which is 60 millimeters. And it was studied in the Disrupt BTK trial. It has only 4 emitters and 160 pulses. And the coronary catheter is the Shockwave C2 catheter, and that has 2 emitters with a 12 millimeter total catheter, and has been studied in several clinical trials that we'll get into shortly. The Yale Cardiovascular Research Core Lab, notably, was the core lab for virtually all of these trials. So they played a really important role in the development of this device and the study of this device in a really meaningful way. So just a shout out for that. This is the M5 catheter. So as you can see, there are 5 emitters. And this catheter is a little bit different in the way that it works compared to the coronary catheter. And I'll get into that in 1 second here. But I just want to show you the diameters are 3.5 to 7 for the M5. But remember, for the M5 Plus, they've added an 8 millimeter catheter. There's 300 pulses. The sheath compatibility does change depending on your size. So for those doing PV interventions, it's really important to remember that, because a lot of our interventions are done through 6 French sheaths here, typically, but when you want to use a 6.5 or 7 millimeter balloon for the iliac or for the common femoral, you have to use a 7 French sheath. And also remember that the working length is 110 centimeters. So you're not going to reach below, the POP, the P1 segment, P2 segment there. And also, depending on if you want to do a case by the radial, you're not going to be able to use this balloon to reach very far if you're not going to do an iliac case. So here's a lesion that I treated previously with severe common femoral disease, which, in many ways some ways is a little bit off-label. Typically, these patients are treated with common femoral end arterectomy as a standard of care. However, this patient was surgical turn down. And so you can see very clearly dense shadowing of very significant calcified boulders and critical stenosis just before the bifurcation of the SFA and the profunda. And this patient was treated with Shockwave lithotripsy alone using an M5 catheter. One trick with this balloon, particularly in the M5 balloon, is that the emitters do not all fire at once. So it's a common misconception that when you press the button, all of the 5 emitters are sending shockwave impulses into the vessel wall, and that's actually not the case. First, the distal 2 emitters fire simultaneously, then the middle emitter fires as the next pulse, and then as the third pulse, the proximal 2 emitters fire. And so if you want to treat a very focal lesion like this one, where you can center that middle emitter right on that lesion, you can then hold the button down for 1 pulse, 2 pulse, and then release it, because that will reset the cycle. So now you will maximize the firing frequency of the middle emitter where your lesion is, and you will not waste pulses in normal tissue surrounding that lesion. And so you can increase, probably 2/3 more, 66% more pulses where you want them, rather than just holding the button down the entire time. So it takes a little bit more, obviously, mental energy and effort to do that and focus on that. But if you do that, you can really enhance lesion modification using the available pulses that you have in that balloon. This is a sort of a very classic case for Shockwave, where you can see here in the adductor canal, as the SFA crosses the femur, there's a very severe calcified lesion there, which is a sort of a classic case for where Shockwave would be incredibly useful here, especially given the length, because it's about 60 millimeters in length. So you can use 1 balloon to deliver all the pulses in that location. And you can see the calcium burden here. There's only 2 very narrow arcs where it's not heavily calcified, but a lot of calcification in that vessel. And this is what the balloon looks like when it's inflated to 4 atmospheres in the peripheral, which is, a huge waste on the balloon, where there's angiographic calcium on both sides, double walls of the vessel. And that was the final result after the angioplasty with Shockwave alone and no other sort of adjunctive treatment. This is the S4 catheter, which is recommended for below the knee use, but you can really use it, in any situation that you feel it's necessary in the peripheral space. it's 4 emitters instead of 5, so hence S4. The number on the device name tells you sort of how many emitters it has. It's 40 millimeters in length rather than 60, and it's 5 French compatible, which is what a lot of below the knee interventions use, only a 5 French sheath. So, and it gives 160 pulses, so it is less pulses. But it's very useful in the tibial space. And actually, this was a case where before the coronary catheter was available, it was used, or I had used it in a coronary case before even the C2 catheter had come out at that point. And this was a case of refractory ISR in the right coronary where the MLA was 2.7 millimeters squared and was a very focal lesion, but we were able to deliver this device with, the S4 catheter, which is still an 014 guide wire compatible catheter, but it's longer and a lot bulkier than the coronary one now, but we were still able to deliver it. And just with 20 pulses at 4 atmospheres, it had fully expanded with an excellent result and a final MLA of 6.1 millimeters squared by OCT. So this is finally the last catheter, is the C2 catheter, the coronary specific catheter, 2 in the title for 2 emitters here. And I think, it's important to remember where in the balloon these emitters are, because that's where you're going to want to really ensure, because this balloon is only 12 millimeters and a lot of the complex cases that we use this for have really long lesions. It's important that we understand where the emitters are so that we can really focus that energy as much as possible on the lesion of interest and not waste pulses again on surrounding tissue. It gives you 80 pulses. Like I said, it's 6 French compatible. Its working length is 138 centimeters. And you can see the tip profiles there, the crossing profiles there. This is the distribution of the length. So here's the distal emitter, the distal radiopaque marker. So what you're going to see is that distal radiopaque marker and that that proximal radiopaque marker. That's the 12 millimeter distance between the two. And then the emitters are actually off center. So they're not exactly, in the center of those radiopaque bands. They're a little bit off center. So the first emitter is 2 millimeters distal to the proximal radiopaque marker, and then there's a 6 millimeter gap, and then you have the final emitter. And the acoustic pressure actually has been shown to decline just 3 millimeters away from those emitters. So if you really don't get it right where you want it, you are going to lose a lot of the effectiveness of the device. So important when you position the balloon that you do it under contrast, that you don't sort of approximate where you think it is, that you really give a nice injection and you see where you're positioning those emitters. And if you're using it for a longer lesion and you want to distribute those pulses, you should make sure that you overlap the device by 2 millimeters in those when you pull it forward or when you push it forward or pull it back, to make sure that you optimize the energy profile across that lesion. And this is sort of a typical case where you have 3 lesions here, the tightest being lesion number 2, and you can see that sort of dog bone wasting in lesion number 2 of the Shockwave balloon, and then at 10 pulses it fully expands. And that's sort of how you also can tell that you've treated that lesion and the vessel has sort of give way with calcium modification, and there's the final stent result. It's also used in in-stent restenosis a fair amount, but I would say you really have to do some form of imaging before you decide to use this up front, because if it's really fibrotic intimal hyperplasia that you're treating, that's just densely fibrotic and scarred and difficult to expand, this device is not going to be very helpful for you. But if it is because the stent was previously not expanded because of calcific boulders or circumferential calcium, ideally, and that's really where this device comes more into use, is when you have that circumferential 360 degrees of calcium and the stent never expanded. This may then be helpful in those ISR cases, but not so much where there's fibrotic intimal hyperplasia. So this is sort of an overview of the trials in coronary disease that have sort of been the foundation for how the device was approved. Initially, there was Disrupt CAD1. Then there came out 2, 3, and ultimately 4. But it's important to know that these were single-arm safety and effectiveness studies and not randomized controlled trials against, say, for instance, roto or non-compliant balloon or, what have you, or cutting balloons or anything like that. They were just really safety and effectiveness trials. So the major one, though, was the third one, Disrupt CAD3, where there were 384 patients. That was the largest of their initial studies. And they all importantly had OCT sub-studies to show really mechanically what the device was doing, to the actual intima and media of the vessel. So comparing Disrupt CAD and CAD1, the important thing is that in CAD1, 38% of patients had concentric calcification, and in Disrupt CAD2, 71% had concentric calcification. The inclusion criteria was a little bit stricter for Disrupt CAD2 with that respect. And in order to deliver the device, about 40% in both cases required a pre-dilatation balloon in order to get the Shockwave balloon to where it needed to go. So that sort of gives you a sense of the kind of lesions that were included in these trials, I guess, is the point of that, and what the crossability of this device is in that respect. And this was the OCT sub-study for the first one, which was Disrupt CAD1, which was 31 patients. And on the second row here of images, what you can see is these sort of jagged areas of black, entering the calcific nodules is the microfractures that you're seeing in the calcific burden of the vessel. And that's what the device does, is it instills microfractures into these areas such that these large areas of calcification can be broken up and allowed to expand when a stent is deployed. And so the calcium fracture rate that was actually seen was about 50% on average post lithoplasty, and a little bit more, 42% on average post lithotripsy, and then about 54% after the stent was deployed in the first OCT sub-study initially. So that means that about half cases in the OCT, you did not see any actual physical evidence of severe fractures of the calcific lesions, interestingly, in Disrupt CAD1. And I won't spend too much time on this study just because it's, was the initial sort of proof of concept study, but the outcomes in terms of the safety profile were extremely good. They did not have any major acute procedural complications in that study. In terms of the Disrupt CAD2 study, this was 120 patients. These patients had a broad spectrum of coronary disease as inclusion criteria, and the primary endpoint was MACE of up to 30 days. And you can see in this one, the calcium fracture rate was 78%, so much higher in this one. And I think part of that is because you had a lot more patients with concentric calcification in this study as compared to Disrupt CAD1, where you had a lot of patients with eccentric calcific nodules. So, it has sort of come about from these trials that that's the most appropriate patient population, which you're going to get the highest utility of using this device, is when you see that circumferential calcium on IVUS or on OCT. And a lot of these patients, 38%, had greater than 3 fractures, so multiple fractures. The acute procedural success was basically close to 100%. 100% had a stent delivered, and then, almost all of those patients had almost no residual stenosis or very limited residual stenosis. Almost all of the MACE events were due to non-Q-wave MI, because of the measuring of the CK-MB fraction after the procedure per protocol mostly. And then finally, the Disrupt CAD3 study, which was the largest one, which was 384 patients. In this study, they actually required that the calcium was 270 degrees or more by OCT or IVUS. And you can see that the characteristics of the patients are similar to what our patient population might be that we treat in the lab. A lot of diabetic people, some current smokers, a lot of patients with renal insufficiency, and an age of roughly 71 years old, with at least CCS2 or 3 angina. The calcified lengths of these lesions were quite long, so 50 millimeters. The lesion length was about 26 millimeters, so not very focal lesions or diffuse coronary disease. with around 65 to 70% diameter stenosis on average, and most of the lesions, or over half, were into LAD. These procedures, a lot of them were done radial, but not as much as I would have anticipated in this time frame when the trial was conducted. So 60%, just under 60%, were conducted radially, and perhaps that's because of the complexity of the coronary disease that was deemed by the operators. And in terms of the procedural characteristics, they were relatively long cases with a lot of contrast used and some fluoroscopy of 15 minutes during those cases. The pre-dilatation was required in 55% in order to deliver the balloon. So, these were, not easy to deliver. The lesions were not very easy to get the Shockwave balloon across initially, at least, I would say. And if you look at the number of pulses, interestingly, in this study, 68.8 pulses was the average pulses delivered. But in Disrupt-C 84, the average pulses delivered was 104, which means that on average, operators used more than one balloon. And that's, obviously not a very cost-effective thing to do given the cost of the device. But at the same time, if you're treating a lesion that's more than 12 millimeters, and you want to do so very, very effectively, you may need to end up using more than one device to get to that, outcome, because there's only 80 pulses in the balloons. And if you have a long segment that you need to treat, 20 or 30 millimeters, you might need to use more than one catheter. The final angiographic results were excellent, with an average in-stent stenosis of 11% post-intervention. And post-IVL, the acute gain was 1.7 millimeters, and then post-stenting, the average MLA was over 6, regardless of the vessel that they were in. And the core lab analysis showed that the major complication was really severe dissection of only 2.1%, and that was only immediately post-IVL. Obviously, those resolved post-stenting after treating finally. And there was a very low rate of any other major immediate procedural complication, with no abrupt vessel closure, no perforations, no reflow, and some patients had sluggish reflow, but a very, very small minority. The freedom from MACE at 30 days was excellent at 92.2%, and then the primary effectiveness endpoint was met at 92.4%. In hospital, the major adverse outcomes was basically MACE, which was driven by non-Q-wave MI. And, some of that, or most of that, is obviously the standardized checking of CKMB for the protocol, and not symptomatic MI or Q-wave MI, we'll put it that way. And you can see sort of at 30 days, very consistent outcomes without a major step up in really any of these. Like we said, the acute procedural success was very good. And stent thrombosis rates were sort of very low, as sort of expected, at 0.8%. We already been through the OCT stub study, so I won't sort of belabor that anymore. This is an interesting, I think, figure, because it shows that whether or not there was a fracture noted on OCT, no fracture or fracture, the final minimal stent area, the final stent expansion, and the final percent area stenosis, or MLA, was no different, whether or not you saw those fractures or not. So the theory is that there are microfractures being created, whether or not we visualize them, even with the advanced technology of OCT. And finally, I'll show you a case that I did not too long ago. Actually, this case was an 89-year-old guy I did at St. Raphael's, where I could not get a balloon across this popliteal CTO. It was very densely calcified, as you can see on the fluoroscopic image on the right. And the balloon was stuck in the lesion, and I could not get the balloon out. I had an 014 wire down into the tibials, and I had used numerous types of balloons to try and get it through the lesion. And finally, I used a rapid exchange barred ultraverse balloon, 1.5 millimeter diameter balloon that would not then come out of the lesion. And it was fractured inside. The balloon shaft was fractured inside this CTO. So there I was sweating. I had to get pedal access through the dorsalis pedis, come up from below, snare the device from below using a catheter, and pull it out through the pedal access site, which I was able finally to do. And then ultimately, with all that manipulation, I was finally able to deliver a shockwave balloon in that area. And finally, after about 300 pulses, it was able to finally fully expand. And then we had a phenomenal angiographic result in that lesion. So this device really came through for that patient, which was truly a balloon uncrossable lesion, one of the toughest, CTOs that I've encountered. So I just want to sort of give us some time for questions. So basically, to summarize this, calcific lesions, whether they're in the peripheral or the coronary, are extremely prevalent. They add a lot of complexity to revascularization procedures. And it's associated with higher major adverse events and even mortality. So Shockwave is, I don't want to call it a novel technology anymore, really, because it's been around for several years. But it basically converts electrical energy into mechanical energy through acoustic pressure waves, and it is used to treat resistant calcified lesions, including those where the calcium is deep wall. It has an easier learning curve, certainly, than existing atherectomy modalities. And just remember that if it's tough to get a balloon into the lesion, putting the shockwave balloon into the tip of the lesion and trying to sort of open it up that way is not going to be effective, because the emitters are not at the tip of the balloon. So you really need to use some form of atherectomy in those cases. So that's all I have for today. And thanks, everybody. I will open it up to Yusuf for questions.
Thanks, Amir. That was a really phenomenal talk. I think there was a lot of very useful information about the design of the technology that can help us maximize the effectiveness, knowing where the emitters are. A lot of really good technical points. Can you just someone who doesn't do peripheral interventions, is IVL in the periphery as much of a transformative technology as it is in the coronary? Because I think in the coronary it's really transformed the way that we can treat calcium. And because I don't do these cases, I don't have a sense of if it's as impactful in the periphery as well.
Yeah, I think it is not only as impactful, but in terms of its widespread adoption, and certainly in the peripheral, it has been around for several years, longer than in the coronary. But irrespective of that, it has received widespread acclaim and adoption in terms of its use. It does have limitations, though, I will say, in terms of the treatment of long, heavily calcified, complex CTOs of the SFA. In those cases, this is not sort of the end-all device to treat those, complex lesions. You do need to bring more up front there in terms of atherectomy to have sustainable long-term results with endovascular treatments in order to really compare it to bypass surgery. So there are some limitations. The length of device is also a limitation in the periphery, because if you think about it, a 60 millimeter balloon in the peripheral is not long. So, if you're treating a 30 millimeter SFA or 35 millimeter SFA, CTO, or what have you, and the SFA is often very calcified throughout its length, this is, even 300 pulses is not going to be effective in those patients. But for the adductor canal, heavily calcified, or for the POP CTO or the focal lesions, this has really been a game changer, I will say, in terms of reducing atherectomy use, because those will often cause distal embolization in the periphery, which can turn a claudican into an acute limb. And that is sort of the worst nightmare for the peripheral interventionist. When you take a claudican to the cath lab and you embolize because you're doing atherectomy and it's in the TP trunk, and now you have no flow down to the foot, that you're spared that essentially a lot of the times with this. And so that's why it's really been a game changer there.
Hey, Samir, this is Steve. Great talk. Thank you very much. Did you see in the Disrupt CAD3, I guess, the one that had the almost 400 patients, how many times they had to use atherectomy, or were there any reports of using atherectomy in order to deliver the device?
I don't think there were any reports of atherectomy that I saw in that one. Did you? No, do you know?
No, I don't know. I mean, that's been my experience, is that it's a kind of a bulky thing, and sometimes you need to make a channel first with atherectomy before you can deliver the shockwave balloon. So I wasn't sure if that was the case in that study or not.
The protocol didn't allow them to use atherectomy or some of the other specialty balloons, if I remember correctly.
Thanks.
Yeah, and I think, there's a lot of people who might view this device as an alternative, only an alternative to atherectomy, meaning you either use roto or you either use shockwave. And if you roto, you don't need to use shockwave. And I guess the question is, even though you've modified the lesion enough to get a balloon to expand, is using shockwave in addition to that to fracture deeper wall calcium going to help ultimate stent expansion areas and also, lower restenosis? I think that's the important question for the future of this technology and others, is to show whether it's not just an alternative, but an adjunctive case in every lesion that is atherectomized, or maybe not. Obviously cost is going to be a big factor in that, but would be an interesting thing to study from an outcomes standpoint.
Yeah, just
Samir,
Go ahead.
Samir, one of the things I think this balloon, because it's so relatively, easy to use, people sort of jump to it right away. And since we don't, in the old days, we would put a balloon, or at least I would put a balloon across, go to 8 atmospheres, and if the waist didn't yield at all, that was an indication for atherectomy. And there's a study that I saw. It's a single center study, and I don't remember where it was, so I apologize. But they looked at NC balloon inflation versus IVL, and showed that they were equivalent. That if you could, in other words, if you could fully inflate an NC balloon, it was you didn't have any gain in intraluminal diameter. And I think the question I have is, do you think we overuse IVL a little bit?
Yeah, I think, your point's well taken, that because it's so easy to use, that it might be used in situations where a plain balloon would just, work just as well, or non-compliant balloon would inflate just as well. It's possible that it's being overutilized in certain cases, and I think that's important because of the cost, from the cost perspective, because otherwise, if it were the same cost, then you could argue that why not use this because it modifies deeper calcium, or what have you. But you're right. I think its ease of use may be causing overuse and increasing healthcare expenditure.
I think it's a good point, but we have to also remember that IVL is a lot safer than NC balloons. It's not, I do think it's more effective than NC balloons. There are some cases that, you could do with NC balloons, but, because of the different mechanism of action, the chances of you getting some type of trauma to the vessel from a high pressure NC balloon inflation, I think, is a lot more than from an IVL. So I do think there's a safety benefit as well.
Can I ask a question, Samir? So I'm curious, sort of, with the new technologies that are available, and then with data that came out from like best CLI, et cetera, how you guys are approaching these patients with CLI
In general, or with respect to this device? Because best CLI,
well, both. So because I don't know that this was used in best CLI, although please correct me if I'm wrong there. And so, like, how, I think those, I was a little surprised by those outcomes. Maybe you weren't, but sort of curious, when you have these patients, if you're using this, if it's focal, if you're looking at, whether their saphenous vein looks good, how the approach is for them.
So best CLI, this technology was around during the best CLI trial, but this technology, best CLI trial, was for several years, and this technology was still also under clinical trials during some of that overlap period. So it was used during some of those patients, certainly not all, and it was at operator discretion. There was no part of this device in that protocol. But what I will say is, I don't know that this device changes our management of the patient in terms of whether we feel it's treatable endovascularly or we should send them to surgery. I don't think that has been a game changer for those patients, because atherectomy can always be used instead, in lieu of this. I don't know that this has really changed anything. Whether the trial itself has changed our practice, not yet per se, because for one thing, a lot of the patients that have CLI, in our patient population at least, are very poor surgical candidates to begin with, and they need to have an adequate saphenous vein for the surgery, which many of these patients, because of their other comorbidities, previous cardiac bypass surgery, or what have you, don't have a great adequate caliber saphenous vein. So the number of patients that we can definitely send to surgery for a great outcome, also depending on their targets, has not been, as robust. So those are, I think, the limitations within our niche practice here in New Haven. That's what I would say in general about that.
John, while you're on, can you talk about the use of the peripheral IVL for TAVR, and the way that you may be able to take cases that would otherwise need to be alternative access and transform them into a transfemoral case? How often are you using it? Is it useful?
Yeah, I mean, it's been certainly that's where I first used the technology, was really in the common iliac and the external iliac arteries. I used it once in the aorta, not so much in the femorals because of the need for the perclose to take there, but it is, I think, quite impressive how well it works there. Now, obviously, in our settings, the patients don't tend to have, signs or symptoms of ischemia in the leg. It's more that, they have a vessel that's, 3 millimeters, 4 millimeters in diameter, and this helps a lot with it. So I think a fair amount different from the patient Samir's treating, but it really has been in some ways allowed us to really push the envelope, especially in those patients who have a nice femoral access, but then have significant iliac disease. And it works remarkably well. I think the one place where you have to be a little bit careful about it is if you're just using it the way we are, which is to make your access bigger, is when you're using it at the origin of the common iliac, right? It's sort of the ostium of the common iliac there. I've seen one case that went a little bit south done down at Bridgeport, but otherwise I've been surprised at how well it works. And if you have, especially when you have segments of normal vessel and then fairly focal areas of stenosis, it's worked quite nicely for it. I am curious if the technology has been paired with a drug-coated balloon at all, because it would seem to me that would be a combination of two things where it might be nice.
You mean drug coating on this balloon itself, on the balloon catheter?
Yeah.
No, it has not been paired. I don't think there's any, and there's certainly no plan to do that as far as I'm aware. Because the only problem with that is that, first of all, when you put the drug-coated devices in, they have to be delivered very quickly, and you can only treat one lesion, basically a 60 millimeter lesion with the M5 balloon. So then whatever you treat after that wouldn't be drug-coated.
Okay.
It would also increase significantly the cost of the balloon, because the drug-coated balloons are significantly more costly than the plain balloons, obviously. So that would not work in their favor, from the company's perspective.
Now, this is asked to John if there are reports of using lithotripsy on the aortic valve. I'm pretty sure there are some case reports of people who've used it.
I mean, certainly Shockwave, the company, is developing technologies for the aortic valve to try to use it there. Yes. I don't know. It was several years ago that I talked to them about their different thoughts there. And I don't know how far along they are with that. I know that there have been sort of, one-offs where people have taken two large balloons and put them across the aortic valve and done it there. But I think one of the questions has been, how would you get a more durable aortic valvuloplasty results if you combined this technique with a plain old aortic valvuloplasty? and they are in the stages of developing such a balloon.
Maybe they should pair up with the Sentinel company, because the risk of stuff embolizing to the brain may be a bit higher. Okay, I think it's nearly 8:30. That was a really, great talk, good discussion. So if there are no other questions, then we'll thank Samir and then close it up, I think.
All right, thanks everybody.